Welcome to HSG's virtual presentation at the OHA annual conference. Today's presentation is titled Patient Share of Care, Measuring Patient Brand Loyalty. And I'm DJ Sullivan, co-presenter is Eric Andrioli, both directors with HSG, and we really appreciate your attendance today. And while we might be physically located in Louisville, Kentucky, the heart of bourbon country, we're excited to be with you in virtual cyberspace today. At HSG, we focus on employed physician networks and help clients around 5 key areas. The first is physician strategy, which includes growth, manpower planning engagements, physician leadership, where we often help clients build and maintain provider leadership structures, performance improvement implementation, which is often returns in significant financial return for our clients, network integrity, which is where we help clients really around patient attraction and retention strategy development. Then lastly, physician compensation, which includes fair market value assessments, hospital-based subsidies, as well as overall compensation plan redesign. Today's presentation, as we said, around patient share of care really fits within our network integrity and physician strategy service lines, and is going to be focused around how do we support organizations such as yourselves in attracting new patients as well as retaining the patients that are currently utilizing our services. As we go through and kind of talk about the overview of where we're going to go today, we're going to first start with having Eric go back and talk about the importance of, and then how do we actually measure patient brand loyalty and what does that mean for our organization. We'll walk through some specific best practices that we found in engaging with clients around a lot of these measurement tools. Then we'll kind of go through 2 specific use cases that we've developed and kind of worked with clients on, and then obviously address any questions or concerns that you, the audience, may have at the end. We also have, this is kind of a background on the educational description and behavioral outcomes that we are hopeful you're expecting from today's presentation. If you have any specific questions or comments, please be sure to engage with the virtual prompter so that you can provide those throughout, and we'll be able to address those questions at the end of the presentation. So Eric, I might turn it over to you to first kind of talk through maybe the why and the what of what patient share of care is.
Sounds great. Thanks, DJ. And so I think, taking a step back, it's really important to think about, what strategic planning looks like nowadays, because nowadays everything is very data driven, and the quality of the decisions that an organization makes during any sort of strategic planning effort is very dependent on the quality of data and analytics that go into those efforts and go into those decisions. So on the screen, we have some examples of data and analytics that come together and inform a variety of strategic outputs. So if we think about something like evaluating the performance of an employed network, or developing a manpower plan, or developing a new plan for service line growth or market and geographic growth, those are all things we spend a lot of time talking with clients about. And so because of that, we spend a lot of time looking at a variety of different data. We might look at, employed practice key indicators. We might look at what productivity is within employed practices. And if we just think about those 2 things, obviously those 2 things are relevant for employed network performance, but they're also relevant for manpower planning. Because if we're thinking about provider productivity, the more busy a provider is, or if all providers within a service line or specialty are very busy, that might tell us something about whether we need more providers. On the other side of the coin, if the providers aren't busy, it might say something about, is there enough demand to bring in more providers? And that can be combined with all the analyses on the left side of this page to bring together any sort of story that needs to be told for a variety of strategic planning outputs. And so things like, provider productivity, things like looking at the market and figuring out supply and demand, things like looking at market demographics and, where are areas of strength and weakness and things like that, looking at access point and drive time analysis, looking at quality and outcome measures, and bringing all those things together to tell the story about where we need to go with any sort of strategic effort. Again, if it's manpower, if it's where do we need to take our employed network, or globally, where do we need to take our whole organization and what does our 5-year plan need to look like? Any of those questions or strategic planning efforts require all of the data that I just talked about to come together and tell a story. And I just give all that as context because we're not talking about any one of those data points I just mentioned today. What we're talking about today is a very important input into that data tapestry, and that's the patient attraction and retention piece. And that is such an important input into any strategic planning initiative. If we're thinking about manpower planning or service line planning or market growth, we have to understand the patient behavior aspect of things. Where are we getting patients? The patients we get, where are we losing them? Where along the continuum are they getting care? What specialist are they seeing? When they go to have a surgery, where are they having it done? We have to understand the patient behavior component. And I don't want to say it's the most important, but it might be. And as I said earlier, all data points come together to tell stories. So no one data point is enough to tell the full story by itself. But when we think about the patient attraction and retention piece, that is easily one of the most important ones. And getting that component wrong can definitely lead to the wrong conclusions when we're developing strategic plans. And so that's why it's really important to have the right data, the right analysis to understand what patients are doing. And so, DJ, if we move on to the next slide, so historically, we see organizations overly relying on data that's either inadequate or doesn't tell the whole story, or the analyses that they're applying to that data, doesn't get them to where they need to be. And when we think about understanding patients and patient behavior, most organizations are very used to using inpatient market share data. That data is often, self-reported to the State Hospital Association and therefore very easily accessible to all the hospitals reporting to that state association. Usually it's really good. You can drill into, a zip code, you can look at DRGs, and you can say, hey, for a given DRG in a given zip code, what is our market share? And that's really useful information. But the big problem is it misses the competitiveness of the ambulatory landscape in any market where you're only looking at inpatient data. Most markets, we're seeing more healthcare be delivered outside of the hospital walls than inside. So right off the bat, if you're only using inpatient market share data to kind of understand the patient preference question, you're missing half the healthcare that's delivered. And it's not even that you can use the inpatient side to represent the outpatient side, because what we see time and time again is an organization may feel very confident that they're getting the high acuity services, that they're getting the surgeries, the joint replacements. But when we drill into outpatient data, what we find is they're missing the joint they're missing the imaging and diagnostic studies that lead to those joint replacements. And that's really useful information that you need to have when you're making strategic decisions. And so because of that, we acknowledge that inpatient market share is useful, but it can't tell the whole story. And so for that reason, we kind of put it into the inadequate bucket. Same thing with the electronic medical record. There's a lot of good information that can come out of analysis by looking at the EMR. We see a lot of organizations doing referral analysis, because if a primary care doc sends a patient to a specialist, a lot of times organizations like to see a field on there to say, hey, who was the referring primary care doc? And then they might mine that field for information to understand where their patients are coming. But the big problem with that is that the outputs in terms of the data analysis are only as good as the inputted data. So if that referring provider field isn't filled out, or isn't filled out consistently, or has bias in terms of who fills it out and who doesn't, that means you're gonna get skewed information when you try to do your analysis. And if you assume that you're getting patients from one group and not getting patients from another group, and then you're making strategic decisions off of that, those strategies might not bear out long term if they're based on bad data or underrepresented data. Because the other thing that we have to think about with EMR data is that it misses care provided at other facilities. So if a patient goes to see a employed primary care doc and we have that on in the EMR, we can see that, and then they come back 9 months later for a surgery and we can see that because we provided both of those services, there might be a whole bevy of services in between that we or our client organization did not provide, therefore doesn't know about, therefore doesn't know that that's missed opportunity, and can't even begin to drill into the question about why did this patient choose other services or choose other facilities for their services, because we don't even know that that happened. And so because of that, we think that, while we don't want to ignore inpatient market share or EMR data or anything like that, we really feel like organizations need to supplement with a claims data approach. And the reason for that is it kind of addresses a few of the gaps I just mentioned. It can provide a holistic portrait of patient care, meaning inpatient and outpatient, meaning if they go to our facility or another facility, we can see that in the claims data. Also, the detail that's available with the right claims data facilitates multiple analytic approaches. So we can understand, timing of one visit versus another. We can understand CPT level data. We can track a patient to say, in an unidentified way that the same patient, saw 3 different physicians, so on and so forth. And so that's really important from claims data. Of course, every data source has a downside. Some data redactions due to privacy protection means that, no claims data source is going to be 100% snapshot of the market. Most markets we work in, on the commercial side, we might be getting 65, 75, 85% of what's going on in the commercial market. Medicare, we're almost always at 90% or above. And so usually when we bring those two things together, it's a very, very robust picture. But we don't want to claim it's 100%, and no claims data vendor or source or tool should claim it's 100%. But we feel that if you're using the right data, it's very representative and very strong to make good strategic decisions on. So important to understand the data sources, but also important to do the right analysis once you get your hands on the right data. So as I said earlier, with enough detail in the claims data, you can perform a few different types of analytics. But the thing we're going to talk about from here to the rest of the presentation is patient share of care. And that's our way of saying, let's find a target patient population, and then let's understand where they're getting their care. And all of those, there's a variety of decision points along that process, but that's what everything boils down to. Is let's take a bucket of patients, let's look at their claims data, and let's just understand where they're getting their care. And so if we think about the steps along that, the first step is to identify the patient population. And it's really important, and DJ will talk more about this, but it's really important that aligns with the business question and analytic goals and the goal of the strategic planning process that we're trying to get through, because there could be many potential definitions of saying, what is our target patient population that we want to perform analysis on? We could say, hey, let's perform analysis on patients who are on the panels of our primary care physicians. We could say, well, what about folks who are coming to our urgent care facilities or our emergency department? Or what if we only want to look at patients with a specific procedure or diagnosis to understand what happened before the diagnosis or what's happening after the diagnosis? And so all those different definitions of patient population are important to understand what's possible and what's not. Also important to understand what the goal is, so you have the right starting point when you're thinking through your patient population. And as I said, DJ will talk a little bit more about that. But then from there, once you understand the patients you're trying to target, then once you get their data and analyze the data, then it becomes saying, okay, well, what do we consider us? What do we consider not us? So that way, when we are, relating things down to percentages and what percent of their care did we receive, we're having the right definitions. Because it sounds easy. It sounds, oh, well, of course it's easy to say who's us and what our system is and what our facilities are. But then when you think about things, well, what about people going to joint ventures, or what about people going to closely aligned practices or facilities? So we might need to take here's a friends and family approach. We have a variety of facilities that it's good for us if patients go to, and then we have a variety of facilities that it's great for us if patients go to, because those might be wholly owned versus joint owned. And so there's a lot of nuance in just kind of how we think about grouping up the facilities that patients are going to see. And then from there, how we slice and dice that to say, well, how do we want to see it? Do we want to see it based on service location, or do we want to see it based on procedure group or rendering provider? And within each one of those groupings, we can say, hey, what percent of patients are we getting? So it can be, what percent of patients receiving an MRI are we getting? What percent of patients, having a joint replacement by Dr. Smith are we getting? And so, the right level of detail really is important in that step 3, because you can slice and dice and be in analysis paralysis forever. But if really what you want to know is, hey, in this region, what are our opportunities for growth? Then you want to make sure you're doing that right analysis and grouping things appropriately at the procedure, the facility level, the rendering provider level, all that stuff kind of boils down into how do we measure actually the patient share of care by relevant groupings in that step 3. So with that said, I think hopefully I've teed up, what share of care is, why it's important, but it's really important to use it correctly. So I'll ask DJ to spend a few minutes talking about that as well.
Yeah, perfect. Thanks, Eric. And so thinking through some of the best practices that, as we believe, kind of talk through this patient share of care measurement that we believe are and we'll talk about each of these in a little bit more detail as well. But as Eric kind of already stated, defining the business question before you actually do anything is what we have found to be by far the most important step, because that question can be extremely broad or extremely narrow depending on which audience you're trying to address, and also what is the current problem that we're trying to solve from a measurement standpoint to develop the right strategy for our organization moving forward. You take that business question that we've defined, and then how do we start to then understand the specific patient population that we need to comprehensively understand to answer that first business question. We then believe, as we kind of start to communicate that the outputs of each of those separate analyses throughout the organization, that the level of detail, kind of those different ways that Eric started to articulate how we actually, if we're looking at something at a facility level, a rendering provider level, a procedural level, that not every level of the organization needs to know every one of those bits of information. And so starting to understand how do we actually communicate specific aspects of the reporting outputs to the right stakeholders is a very crucial part. And then into number 4, saying, okay, we know there's most likely going to be incremental things we need to understand once we have kind of the big picture. So then how do we start broad and start to get more narrow, while always keeping in mind the understanding of what that initial business question is and the population that we're measuring data around. So those first 2 bullets we're probably going to harp on pretty significantly throughout the remainder of the presentation, as we find them to be by far, they're 1 and 2 for a reason, as they're very crucial to the overall success of what we're trying to accomplish from a strategy development standpoint. Then the last piece, number 5, really gets into as we measure, especially as you start to get around the claims data aspect of things and look at the ambulatory space, we find there tends to be a lot more factors, both from a provider and a patient level, that are going to impact the strategy that you're trying to develop to address the business question. And so we need to be aware of those, because that's going to impact where we're at now, and also how do we think we're going to change and shift that, obviously with the goal being for pretty much anything we measure, we want to be able to manage. And so understanding all the factors that are going to impact our ability to manage that metric moving forward, we believe are critical. And we'll kind of talk through, like I said, each of these in a little bit more detail.
And DJ, I think that it's important to note that those first 4 steps are universal to any analysis, really. So, we're looking at it through the lens of patient attraction, retention, and patient share of care. But, any analysis you do, those first 4 points are, really good best practice.
Yeah, completely agree. So first, as it relates to the business question, as it relates to first the patient share of care aspect of things, are really having a clear articulation of what we're trying to measure, and from from an overall strategy development standpoint. So we have a number of examples here of things that we hear from clients very regularly on really what's the business question we're trying to answer or ask and then answer for ourselves. And so second one down, our patients, do they have difficulty accessing specific services either within our sites of care or in our region specifically? Fourth one down, what are some of the primary care providers that are feeding our aligned or employed specialists? And so these are just a few examples of ways in which we start to, depending on what that question is from clients, the things we hear most frequently is, how are patients utilizing our care comprehensively, and what leakage, patient leakage opportunities exist for us to obviously retain patients that are already utilizing our services, and or how do we attract new patients into our sites of service. Those are, if you boil it down to two things, that's kind of the two buckets of areas where really everything's coming down to, but you can be either extremely specific in that ask or extremely broad. And so one specific example is an engagement we've been working with a client on recently around orthopedics. Is they're very focused on developing an orthopedic subspecialty and subspecialization within their service line, where they're looking very procedurally at a specific number of services, and they want to understand more geographically, where are these services being done and where are the patients going to receive those services, and is there obviously opportunity from us both from an inpatient and outpatient perspective to bring that into our system in a more comprehensive and cohesive way.
And DJ, I think the only thing I'll add is, all these questions on this page and the additional buckets and example you talked about, it's not like one analysis can succinctly answer all these questions. And so back to what I talked about earlier, there might be other types of analyses that need to go in to answer the business questions. Obviously, all the questions on this page, the patient share of care aspect is insanely important to answering. But it just underscores what DJ talked about in terms of the importance of answering or identifying the business question, is because then it helps you identify what analyses you need to answer that.
Yeah, thanks, Eric. The next piece, getting into actually how we define those patient populations. So I might actually start on the very far right-hand side of this of saying, okay, a use case of client, someone we've engaged with recently saying to us, we really want to understand patients that are within our employed primary care patient practices, inside our primary care practices. We want to understand those patients specifically and how they utilize all of their healthcare services. And so this to us, for most clients, is obviously these are patients that ideally are in our system on a somewhat regular basis, given they're there for their primary care service needs. And so how are they comprehensively then using all of our healthcare services? Are they using us for all of their inpatient procedures? Are they using us for their outpatient imaging? Are they, if they're having other outpatient procedures done, are they using an ASC that we're aligned with or have a joint venture with in some way? Those are patients that most frequently we find from clients, they have the best ability to retain within their system. Obviously, as you then kind of look at these other patient populations, depending on what we just talked about, what business case we're trying to address, that each of these patient populations, as you look through them, is going to utilize care extremely differently. And so there's always trying to think through, how is this patient population going to utilize their care? And is it going to impact the end result of where we're trying to get to? Because our strategy to support and around each of these separate populations most likely needs to be different. We probably are going to have a very different strategy for retaining patients within our primary care setting than we are around patients that are using our ED on a regular basis. That those are traditionally just going to be very different types of patient populations that we need to understand them differently and understand their comprehensive utilization of care. And develop strategies to, support each of those. Anything to add to that, Eric?
No, very well said.
Then as we get to how we actually report levels of information to key stakeholders within the organization, then how that obviously then relates to drill downs, that we found there's kind of three core components within organizations and departments within organizations that are utilizing this type of reporting most frequently and finding most value in actually developing a strategy from the analyses that are being completed. And so that becomes the top executive leadership, where we have found that really patient share of care, depending on how we're measuring that, if we use the example of patients that are utilizing our ED, how are they, what percentage of their total care are we comprehensively keeping within our system? If that was our measurement, really the executive level, what they probably need is on a monthly, quarterly dashboard, whatever that looks like, what does that keepage percentage look like? Maybe it's 70% of the comprehensive care services for patients utilizing our ED, that's staying within our system. How is that today? What's our baseline? How is that incrementally improving or not improving over time? And how do we continually, at least at the highest level, understand that at the executive leadership standpoint is kind of where we find that stakeholder reporting to be most valuable. As it gets into then the marketing department, so this is the second department where we're kind of starting to get a lot more into, okay, how does that percentage, which we just measured for our entire ED patient population, how does that differ based on geography? If we have multiple hospitals within our health system, is that ED, is that patient population at our flagship center the same, and our keepage rate the same as at one of our other locations across town? And how does that differ? One, by geography, by service line, and then also by some of the provider types, because from a marketing perspective, that obviously helps us start to develop strategies around how do we be more targeted about educating those different patient populations around the comprehensive services we do have, and then how do we, make sure that we're educating the right groups of people, the right groups of patients in the right care settings as we start to go down that rabbit hole. And then the last piece around the strategic planning department. So this is going to become a lot more around, the specialty and primary care recruitment efforts, as Eric talked about a number of slides ago around manpower planning. We find a lot of this data around how are patients leaking. Are they leaking because, one, we understand our orthopedic surgeons are more or less capacitated out. They're working as hard as they possibly can. But we still understand that patients in specific regions where we feel we have those services are actually going to competitors. Is it simply because we don't have the capacity to support that service line in a more comprehensive way? And should that be impacting our longer term recruitment and specialty recruitment planning efforts? So those are kind of, as we talk through things, kind of the three main stakeholder groups where we find a lot of this information flowing through, and obviously the level of information and the detail varying by each in kind. And the last piece, as it gets to the last best practice portion that we talked about, was really understanding, as we start to look at data in this more comprehensive way, that there are what we define as kind of patient and provider factors that we find need to be very front and center as you start to evaluate and look at what the data is telling you. Because there are some things in how we measure all of this more comprehensive care than a lot of organizations have historically, that as we start to understand the ambulatory space in a lot better manner and understanding how patients are utilizing that ambulatory space, that as you kind of look down the right-hand side, providers obviously have a very large impact on how patients utilize that outpatient setting for their services. And so there's going to be, relationships that they have. There's going to be the health system relationships that they have. What are the access issues for getting patients into a cardiologist that's employed by us quickly compared to an independent cardiologist that can get a patient in half the time? That those are just factors that we need to understand, that the providers have a lot closer touch on than we probably do from a data perspective, and getting their input and insights into how they believe their patients are utilizing care is very crucial to understanding, one, once we have a measurement point, how are we actually going to shift that? really comprehensively engaging providers around that discussion around what we think we can do to retain more patients or attract new patients into our system, those providers are going to be very crucial to the success of being able to do that. And then the other piece around the patient factors, that there's simply, as we know in healthcare, there's always going to be how long does it take for a patient to drive to their cardiologist or to their PCP, and is there someone closer? Are there insurance issues that we need to be aware about, that we really just don't have the right coverage for a specific patient population? And if we start to identify that there's a lot of leakage around a specific payer or type of payer, then maybe those are things we start to address. And so a lot of those different patient factors, which is you can kind of read through them as well, but those are things that we also just need to be very aware of as we start to think through what are the strategies that we need to develop to shift some of these measurements over time. And so, Eric, with that, we have two, I guess, use cases to talk through. I might talk through the first one, and then and obviously chime in as you want, and then we can kind of go through the second one, if that makes sense to you.
Sounds great.
Perfect. So for everyone in the audience, what we'll do for the first use case, we're going to kind of go through that whole methodology that we just talked you through of best practices using two specific client problems. And so that we've worked with in recent past. To the first one, and a lot of words on the page, but really it boils down to an organization that we engage with. It's a larger healthcare system in the Midwest, where they wanted to, we've been measuring patient share of care around their primary care patient panel for an ongoing number of months and quarters. But they really wanted to understand, so we had a good grasp first on how their primary care patients utilize their healthcare system. What we wanted to do is then start to look at their urgent care patients and say, how do those urgent care patients utilize their care, if differently from traditional primary care patients? So in doing that, there were kind of three different ways we wanted to look at things. Is first say, so any patient that utilizes one of their urgent care locations, we put into the bucket. So this kind of gets into, we defined the business case. Now we're getting into how do we actually define the patient population. And so for this specific instance, there's actually more or less three patient populations. One, in aggregate of any patient utilizing urgent care within the system, any patient that utilizes urgent care but did not use an employed primary care provider. And then the last grouping of patients is a patient that utilized urgent care and also utilized an employed primary care provider. And we'll talk through some of the specific outcomes as well. But really what ultimately we were able to find is that urgent care patients that did not utilize traditional primary care, they were more or less using urgent care as a complete substitute for their primary care service and not a supplementation. And that those patients that utilized urgent care and primary care were almost always far more loyal to the healthcare system than those patients that utilized just urgent care. So I know there's lots of moving pieces here, but we'll talk through some of the specifics in a little bit more detail. The first is those three kind of patient cohorts as you look down the left. And then we have, as you move along, what is our percentage of total comprehensive services that we were able to keep within the system? And so, as Eric talked about earlier, we have, for this example, we had kind of owned locations, which are fully 100% owned entities of the health system we were engaged with. They also had partners that were around joint ventures, some other ambulatory partners in the market that they wanted to measure separately. And we aggregated those together to calculate their total share of care percentage. And so as you kind of look at that first patient cohort across the top of any patient that's utilizing their urgent care locations was about 170,000 patients. And you can see the expected reimbursement that came from that patient population. And for this example, the client was capturing about 61.9%, which you can really interpret as 62 cents of every dollar that those patients in their urgent care centers that they're spending on their healthcare services, inpatient, outpatient, within the physician offices, whatever it may be, 62 cents of every one of those dollars is being captured by the health system, either through their own or partner locations. So you can see that percentage, it's 62%. I mean, that feels like a very positive number. We're capturing, just over 60 cents of every dollar those patients are spending. As you kind of get that into the subsequent cohorts of those patients that first utilize urgent care but don't use primary care, that percentage drops by a few percentage points to about 59 cents of every dollar. And then the last cohort of those patients that utilize the health system urgent care and primary care as well, you can see that percentage jumps upwards of 18 to 20%, depending on which cohort you're comparing them against. So a huge increase in the ability to retain the patients within the system if they're utilizing both urgent care and primary care. The issue that comes from that, as you kind of look through the data, is the overall volume of patients is very small compared to the total. That's a very small population that's using both urgent and primary care, with the predominant portion of that patient population being those that are using just urgent care locations, or as I said earlier, it's more or less a complete substitute for primary care, which obviously is greatly going to impact this health system's ability to educate those patients on their ability to retain them within the system, because they're not always using their primary care sites of service as well. This is a graphical representation of a lot of the same data that we just looked at. So you can kind of see that first patient cohort on the left at about 62 cents of every dollar being kept within the system. So the blue being the portion that's staying within the system, gray being other sites of service. The part that I wanted to draw attention to is on the right-hand side, whereas I talked about that earlier patient cohort that we've been measuring on an ongoing basis around just the employed primary care patients. That share of care percentage has been around 70% is where it's ended up kind of globally for that health system. And so as you then compare that urgent care patient population of about 59 and 60%, that there's a very significant reduction in obviously our ability to keep those patients within the system. But then to add on to that, those patients that are using urgent care and primary care, even compared to that comprehensive primary care patient panel, that is still an 8 to 9% increase in our ability to retain those patients within the system. So obviously a lot higher loyalty from those patients that are using both those sites of service, even compared to our traditional primary care patients.
DJ, that's fascinating. I guess I've got two thoughts. I mean, it seems like this would have big implications about the urgent care strategy for an organization and the purpose of those access points and whether those access points are getting used as the organization intended. Because I think I've heard a lot of organizations talk about the urgent care strategy as a way to provide additional access points to their existing patients. And so whether it's after hours or if there's a long wait to their existing PCP, then there's an urgent care option. But if I'm interpreting what you're saying correctly, it sounds like this data is showing that that's really not how these urgent cares are being used. These urgent cares are being used by people who don't have an existing relationship with this organization's primary care doctors. And that shows not only in the type of patients who are showing up in the urgent care, but then they're also less loyal once they leave the urgent care as well, correct?
Yep, you're spot on. And so that's really kind of reframed the strategy they're trying to develop as a result of this, is that they understand that patient population utilizing their urgent care locations is predominantly not a patient that's utilizing their service for anything else comparatively. And so they're trying to, focus on what is the education and provider and access points as relates to those urgent care centers as a result.
Yeah, that's interesting. The other thought I had was, as it relates to our earlier comparison with inpatient market share. I mean, I think about, if an organization was just looking at inpatient market share and maybe it showed that they had, a strong market share and, therefore they had a good brand presence in the market as it related to, inpatient services. That's useful information, but it doesn't tell you the effectiveness of access points or different access points. It doesn't tell you how those patients are, ultimately ending up, within the walls of your inpatient facilities. It just says that, we're along the way, we must be doing some things right to have a strong inpatient market share, but it's not as actionable because, this is telling you, hey, what type of access point is resulting in, patients going on for downstream services. And it seems like super powerful stuff.
Yep, completely agree. So as we move to, there's two other pieces I'll touch on quickly, just due to time. But as it relates to, first, we pulled out some high-level priority service lines that are inclusive of inpatient and outpatient procedures within the service line. And as you look through these, obviously the length of the bar is the dollars spent by those patient populations on each of those services. And as you kind of look down and compare, like within cardiovascular, you see that for that urgent care overall grouping, they're capturing about 63%. The urgent care without a PCP visit, about 62%. So those are roughly the same. And then once again, that urgent care with a PCP visit jumps by upwards of 15%. And so that's fairly consistent, that same standardization as you kind of look down, except for surprisingly oncology, which was one thing as you look at that oncology service line, the patients, regardless of if they're utilizing our primary care or not, are consistently using the health system for their oncology services, regardless of how they're actually entering the system. And so that's actually also enabled the health system to start to understand what is it that we're doing around oncology that is different from our other key service lines from an education standpoint and from a provider placement standpoint. And so being able to kind of take some of those strategies that have been developed at the service line level and start to expand that into other service lines has kind of been some incremental work that's taken place. The last piece to touch on is the far right-hand side of this. There's lots of data here, but if you kind of just focus on the health system, that original primary care patient panel share of care is that data on the right. And so there's a whole slew of about 25 service lines that have been developed. And really the takeaway being that for everything in red, it's showing that there has been a more than 10% difference in how urgent care patients utilize those services from a patient leakage standpoint compared to that traditional primary care patient population. So it's very impactful for the organization to start to understand, these are service lines that of all of our 25, 18 of them or so, that patients are more or less utilizing care in the same way. So it's not just service line specific for instance, but it's how, to what Eric said earlier, that it's actually more an access point thing than a necessary service capability thing of, patients that are entering through urgent care are more or less just utilizing their comprehensive care services much differently than our traditional primary care patients. And we develop a strategy to support that patient population and their utilization. Eric, with that, I might jump to your use case and maybe let you start to talk through everything a little bit.
Yeah, and I think part of the reason we chose these two case studies is because there's a little bit of a juxtaposition, because on one side of the coin with what DJ talked about, the main goal was to say, hey, are we capturing all the patients we need to capture? And that was not necessarily the main goal of the analysis that was sought by this example client. This client was pretty confident that they were getting everyone they needed to get from their from all their access points, be it urgent care, primary care, ED, wherever. They have been working on keepage for years and they're great at it. Their main question was to say, now that we've perfected that, what risk or opportunities have we or are we creating for ourselves as we venture into value-based care, value-based contracting, as more of our dollars get attached to value-based incentives? Are we creating risk because we've essentially built a model that excels in fee-for-service? And the example that they wanted to start to tee up was back pain patients, because they had some separate data that, from their own self-employed or self-insured group of employees. They knew that they were spending a lot on their self-insured employees with back pain, and so they wanted to take the same patient share of care approach, but look at it a little differently. And so what we did is we looked at their whole metropolitan service area, and we captured all data, all claims data for any patient that had an ED visit or an office visit with a back pain diagnosis. From there, we did some things. We excluded some patients, if they had certain red flag diagnoses like cancer, where it said, hey, those patients, the care protocols might be a little different, so we don't want them to create noise in the analysis. So we excluded those patients, and then we grouped all the patients in the metropolitan area up into simply two groups. One was the group of patients who came to our clients' access points. The other was a group of patients who went anywhere else. And then we compared what happened after the back pain diagnosis. And we specifically looked at, a group of target procedures. So the main question was, if we think about imaging studies like X-ray, like MRI, and there's a lot of information out there to say, what is appropriate in terms of X-ray or MRI. And so we're not diving into that, but we're using that information to say, well, let's at least look at those procedures, because it's, there's scrutiny out there about that. So we should look at them. And then we also looked at, escalation to surgery, mainly, fusions, decompressions, and the like. And so when we did that, we found some pretty interesting things. So the first thing we looked at was that ED cohort of patients. So anybody who's come into the emergency room. And the first thing we looked at is, okay, what, this is almost a traditional market share view of things, to say what emergency rooms are these patients ending up at. And so we basically the top two facilities were our client facilities. So again, that's good. But then the important thing on the following slides says, okay, after they go to our emergency rooms, what are they having done? And if we looked at our patient, or the client's patient cohort. So on the left-hand side, this is all the ED patients showing up with back pain. And each row you need to look at somewhat independently, because each row tells you the percent of patients that are having that service. So the way to interpret this is, and I'll pick on MRI since it's highlighted. The way to interpret this is 19% of patients who come to our clients' facilities with back pain, 19% of those get MRIs. If we compare that to all other back pain patients showing up to other EDs, if we look at all those patients, only 10% are getting MRIs. So the escalation to imaging was quicker, was more intense at our client facilities than at all other facilities. And so that's interesting, but it gets more interesting when we look at the office side of things. So DJ, if you want to move ahead for us. So now if it's the same type of graph, but instead of looking at it through the lens of patients ending up in the emergency room, it's patients who first go to any physician office for back pain. And there's some very interesting things here. Mainly, if you look at the left side versus the right side, at our client facility, they are more likely to get imaging, more likely to get surgery, and less likely to get chiropractic manipulation. And that kind of makes sense when we think about who our client is. They don't employ chiropractors, so their patient flow and their patient referral is going to look a little different. But still, when we think about the intensity of services, X-ray, our client cohort is getting X-ray at half the time, whereas all the other patients are getting X-rays 27% of the time. So we're very cautious to not make value judgments here about what's good or what's bad. There's additional analysis that needs to happen to do that. However, it's important to know where we need to start and where we need to look into for those extra analyses. Because if we think about patients, getting X-rays more often, or getting MRIs more often, or getting MRIs quicker, in a fee-for-service world, that's great, and maybe that represents client has built great access protocols. So our clients' patients can get the care they need. They can get it quicker. They're more likely to be able to get it. That's one interpretation. The other interpretation could be that this organization going into value-based arrangements has created some risk for themselves because they might not be able to deliver care as efficiently based on some of these protocols, and their total cost of care for these patients might be higher based on some of these findings. So that's really interesting. The other thing what we did that I'll just very quickly mention is that we looked and said, okay, well, the whole chiropractor thing is weird, and our client doesn't, anybody coming to our client access point, it's not going to be a chiropractor access point, whereas out in the general population, people are more likely to go to a chiropractor for back pain. So we took all those patients out of it, and we said, well, what if we just take all the chiropractor patients out of it? And the findings we had were actually still very, very similar. More likely to get x-rays, 4 or 5 times more likely to get surgeries, if they come to our client facility versus other facilities, even when we throw all the patients going to a chiropractor for their initial visit. Even when we throw all them out, we're still seeing the same patterns. So really interesting stuff there that has pretty significant implications on what the organization's strategy is. And I think a pretty good juxtaposition and pretty different to the case study DJ talked about.
And so, Eric, has that started to cause the organization to think through, are they starting to go down the value-based reimbursement path and start to think through their strategy development around that a little bit more? Or has this more just been informative to them at this point?
Well, I think it's causing them to it's good information to know how quickly they should do that.
Yeah.
And it's also good information to accelerate their readiness. Because if you think about if they were to apply this framework, to multiple disease states and multiple diagnoses, they know where they need to spend time and where they don't. And so back pain, they have to, work on the protocols a little bit before they're ready. Whereas other patient cohorts or other patient groups, diagnosis groups, they might be ready. They might already be ready. So it's definitely helping them accelerate and also time correctly.
That's very, very insightful stuff. So I think with that, we'd like to obviously thank everyone for participating and joining us today. Obviously, if you have questions, we're going to address them live on the date of the actual presentation, or you can submit them, we believe, through your virtual platform, and we'll make sure we address those as quickly as possible. But we truly appreciate your time. Obviously, if you have questions around patient share of care, criteria, measurement, what that looks like for your organization, how you develop strategies around attracting and retaining patients for longer term, please, obviously, you should have our contact information. Feel free to reach out to us directly or kind of submit everything through OHA in either manner.
Thank you, everyone.
Take care.